Good evening, everybody. Okay, my name is Jessica, and I'm the health educator for West Milford Health Department, and I'm also the health educator for Ringwood Health Department, Wanacue Health Department, Pompton Lakes Health Department, and Wayne Health Department, and I also work for Chilton Medical Center, which is part of Atlantic Health System. I'd like to thank you all for coming this evening. We have 3 panelists tonight. Each one of the panelists is going to give a brief presentation to share their knowledge on Lyme disease and tick-borne diseases, and then at the conclusion of each of their presentations, we will have a question and answer session, so you guys can ask the panelists questions that you have about Lyme disease. We ask that during the question and answer session that you refrain from asking very personal questions about your own health and diagnosis and possibly any medications you might have taken in the past for Lyme disease, and just keep it very general. I'd like to introduce our first panelist. Her name is Dr. Rowe. Dr. Amy Rowe joined Rutgers in 2010 and is the Environmental and Resource Management Agent for Essex and Passaic counties. Her background is in water chemistry with a concentration on the fate and transport of contaminants. Amy has worked in stormwater management for more than 10 years, and her outreach programming has focused on green infrastructure and urban environments and green jobs training programs. Amy earned her Ph.D. from Rutgers in environmental science. I'd like to welcome Amy.
So with that kind of introduction, you're probably thinking, why am I talking about ticks and tick biology? But I'm also the Master Gardener Coordinator here in Passaic County for Rutgers Cooperative Extension. So I've been doing these kinds of talks for a while. But real quickly, I don't have a lot of time, so we'll get through this. I just want to thank my co-author, Pete Nietzsche. He wrote this talk, and I am adapting it and presenting a slightly different version. But just a little bit about Lyme disease history. It's named for Lyme and Old Lyme, Connecticut, because there was an outbreak of many cases there way back in the 70s. And you can read all these scientific things, but what I'm really going to focus on is the northeastern focus of this disease. You can see the number of reported cases of Lyme are very much targeted more in the northeast part of the country, and specifically in New Jersey. Here are the numbers that are confirmed Lyme disease cases by county. You can see Passaic is moderate at 190. Don't go to Morris County or Monmouth County. I actually had a typo on this slide once that said that Morris County had 4,000 cases, and everybody flipped out. But that's just to show you the distribution across the state. But I really want to get into the basics of ticks, and then we'll get into some landscaping and gardening, so you know what types of plants to plant and what types of plants to avoid to help protect you from Lyme disease and ticks. And so the deer tick, or the black-legged tick, is the main culprit here. You can see it's very tiny. The female has a red color on her abdomen, and the male is kind of a grayish and they both have a black upper section. The dog tick or wood tick does not transmit Lyme. This is a slightly larger tick, and I'll show you a scale in a minute. But this tick can carry Rocky Mountain spotted fever, so you're not out of the woods completely if you have this on you instead of a deer tick. But getting back to those deer ticks, they have a 2-year life cycle. They go through several different stages, the way that many insects and arachnids do. But the thing about ticks is that each life stage requires a different host. And the females have to have what's called a blood meal in order to reproduce. And so it's kind of based on what they're feeding and what their host is on. So the female adults in late May lay, I'm sorry I don't have a pointer, but they can lay up to 3,000 eggs. That picture in the middle is a large female laying her eggs. And so after the female lays her eggs, the eggs usually hatch in August, and then they have the larval stage. Then those babies, the larvae, have what they call their first blood feeding. So I don't know if you guys know Rambo, like first blood. This is where they take their first host, they have their first feeding. It's usually small animals, birds, mice, chipmunks, They're not usually on deer or humans at this stage because these are very, very tiny. Those dots in between the chipmunk and the bird are to scale for how small the larvae are. If it was on you, it would be smaller than a freckle. I mean, they're teeny tiny at this stage. Then after that first blood feeding, the larvae remain dormant over the winter. So over the winter, they're hanging out. You can see that picture with the penny. You see the different life stages, the larvae, the nymph, and the adult. You can barely even see the larvae. But then going into the next summer, the larvae molt into their 8-legged form, which is called the nymph. This is when the second blood feeding occurs, and this is usually with the larger hosts, the mice, chipmunks, dogs, humans, and most cases of Lyme disease are transmitted by this nymph-sized tick. So the nymph is slightly larger. If it was walking on you, you could see it. And then those nymphs will molt into the adults, which you could definitely feel that on you. And then the females have a third blood feeding. And then that is often when they end up on the deer, when they end up on humans, when they're slightly larger. And then the cycle repeats all over again. And so just to reiterate the high risk period, so those nymphs are the ones that are really transmitting the disease, and they are mostly active from mid-spring, mid-May to early July. So you really want to be careful with your activities. If you're out in the yard, make sure when you come in you take a look at your clothes, look at your skin, possibly shower off, have somebody else check your back, your neck, your armpits. And then the adults tend to be active in the fall, and they can transmit the Lyme as well, but the nymphs do transmit the majority of Lyme disease. So here are some 2-scale drawings of the different ticks. So the deer tick, the black-legged tick, is the one at the top with that female with the red abdomen. Then there is the Lone Star tick, which is not so much a problem up here in North Jersey. They have found it in Monmouth County and to the south. And then the dog tick is the bigger one that you'll often find engorged on your pets, on your dog. Those dog ticks, they're really big. Like if you have one crawling on you, you can really feel it. It feels like a spider, or sometimes they get in your ears, they're behind your ears, they're really creepy when they get on you. But those dog ticks, again, the dog tick and the Lone Star tick do not carry Lyme. And with regards to the deer ticks, only the female can carry and can transmit this disease because the males do not have a blood feeding. Only the females do because they need that in order to reproduce and lay their eggs. And so even if you have a male on you, they can attach, but they actually don't transmit the Lyme disease. So just a quick identification difference. You can see how much bigger the dog tick is compared to the deer tick, especially, and the male deer tick is even smaller than the female. But you can see the coloration difference, you can see the size difference, and so they really are relatively easy to identify. But if you have any questions, you can bring a tick to the extension office, and I'll give you my information at the end of this talk, and we can identify it for you under microscope. We actually look at other parts, the underparts, believe it or not, the anus is actually different on these two ticks. And so to really get down to the nitty-gritty, we can tell you for sure if you have a dog tick or a deer tick, but what extension cannot do, we cannot tell you if you have Lyme disease, we cannot test you for Lyme disease, we can't test the tick for Lyme disease. So just to be clear, extension does provide some services. Our office is in Wayne, but we cannot actually test you for Lyme disease. So please speak to your doctor, and hopefully the other doctors on this panel will talk about that. But what I really want to focus on is gardening and landscaping to avoid ticks and to prevent ticks in your landscape. So ticks They can't jump, they can't fly, they can only get on you by crawling. So you need to avoid shrubs, logs, rocks. Like, don't sit on a fallen log in the woods. Don't sit on a rock. Make sure that you're keeping your grass relatively short, because they're literally just waiting for you to walk by. Like I said, they can't jump, they can't fly, they're not swooping down from above. So just keep that in mind and take a look at your lawn and your landscape to try to see where they could be hiding. But here are some plants that you can use in the landscape because they're deer resistant. The deer are carrying the deer ticks. So two of the easiest ways to reduce the possibility of ticks in your landscape is to reduce the deer and reduce mice. Mice are also a major carrier. And so we want to plant deer-resistant plants. And here's a list. I'm not going to read them all. But deer really don't like things that have a pungent smell. So they don't like oregano. They don't like, they don't like mint. They don't like lavender. So just take a look at this list. If you have any questions, I can certainly make this PowerPoint available to anyone that's interested. But these are the plants that you want to put in your landscape so that generally the deer will browse somewhere else. If they get desperate, they may eat some of these plants, but they're not preferred. So here are some plants you want to avoid. Basically, I'm sure you guys know about hosta. Deer love hostas. They will seek hostas out. They will eat them to the ground. So also sunflowers. I experienced major deer browse last year. They also ate those to the ground. So you want to avoid the plants that they prefer because you want to dissuade them from being in your property and walking on to someplace else. And then Japanese barberry, I was speaking earlier today. Japanese barberry, it's not a deer preferred or deer resistant plant, but it is an invasive in the landscape. And there's research done by the University of Connecticut showing that Japanese barberry harbors more ticks than many other plants. And removing it can reduce your tick population by up to 40%. Those were the numbers they were finding. And I can send that report to you if you're interested as well. But getting back to what you can personally do, aside from your gardening and your landscape plant choice, you can also outfit yourself so that you're ready to avoid ticks at all costs. You want to avoid those grassy, shrubby areas. Make sure you're not brushing against them. If you're hiking, stay on the trail. Don't swipe all of those plants that are on the side of the trail. And then when you're out there, you really want to wear light-colored clothing, not because ticks hate that, but because you can see them easier if you're coming in from your walk. And I know it's kind of dorky, but tuck your pants into your socks because ticks really like the edge between clothing spaces, so between your sock and your pants. If they get on your skin, sometimes they'll be between your skin and your underwear. They like those creases. They like to be in warm spaces. So again, check your armpits, check behind your ears, check your back, the small of your back. But those are some things that you can do. But in terms of some chemicals, I know some people don't like to use chemicals, but there are repellents out there. Anything with DEET, D-E-E-T, can be used on skin. Again, it does not kill ticks. Permethrin is a chemical that will kill ticks. And I'm not allowed to recommend actual product names, being a state government university, but just Google permethrin and you'll find them. There are also lots of essential oil-based recipes out there. You can find them as well. So those are some things that you can do to put on your skin to repel or kill those ticks. And then finally, around your house, you really want to reduce tick habitat, to reduce mouse habitat. So make sure that you're clearing brush piles. Don't keep piles of leaves near the house. Make sure that you're keeping your children's playground spaces away from all this tick habitat. And also, again, don't forget about the mice. Good hygiene, landscape hygiene around your property is really important. So if you don't need those bird feeders after the winter, bring them in. If you don't need those salt licks, bring them in. Remove those wood piles. If you have stone walls that are not functioning or are starting to fall apart, mice love those types of things. And then you can kill mice with pesticides. That's up to you. And you can also spray for ticks across your whole landscape as well. But mouse traps work great, the plain old spring-based ones. But you really want to manage the deer population around your property, manage the mouse population, and those are really the big things that you can do at the landscaping level. So if you have any questions for me, or if you want to come to our extension office, here's our address, here's my phone number, there's my email. If you need anything, we are open Monday through Friday. And if you are going to bring a tick, please bring it in a medicine bottle container. Don't put it in the freezer. Don't put it in alcohol. People do a lot of different things thinking they're preserving the tick. Just throw it in a medicine bottle. Just leave it alive, and we'll take a look at it for you. So come on down if you need anything. But that's my presentation. So on to the next panelist.
Okay, next I would like to introduce our next panelist. Her name is Dr. Gaito. Dr. Gaito is a rheumatologist in private practice for 26 years in Basking Ridge, New Jersey. She was one of the founding members of the International Lyme and Associated Diseases Societies and served 2 terms as its president, 15 years on the board of directors, and 15 years as the chairman of the ethics committee. Dr. Gaito's primary focus is the relationship and differentiation of Lyme disease and autoimmune disease. She is currently participating in 4 research studies, 2 with the Columbia University Lyme and Tick-Borne Disease Center, and 2 with a private lab. The focus of all 4 studies is the early detection of Lyme disease with new blood tests. Thank you, Dr. Gaito, and I'd like to introduce her, and she's going to present now.
Thank you, and thank you for inviting me tonight. So I'm just going to give a brief overview of Lyme disease, the different stages, a little tiny bit about ticks, and then I'll take any questions if you have them. So Lyme disease is the most common vector-borne disease in the United States. You hear that term a lot. A vector is actually an organism, usually an insect, that transmits a disease from one organism or plant to another. It's caused by the bacteria called Borrelia burgdorferi. Lyme's a bacteria, it's not a virus. And the type of bacteria that is called a spirochete. The other spirochete disease that a lot of people are familiar with is syphilis. Transmission occurs when an infected tick that normally feeds on deer or mice bites a human. And not all ticks carry Lyme disease, as Dr. Rowe mentioned, most commonly deer ticks, less so by wood and dog ticks. And as Dr. Rowe mentioned, you really feel those ticks bite you. Also, very infrequently, but occasionally in this area, we also see Lone Star ticks. They have a white dot on their back, and they carry some other diseases besides Lyme. Ticks may also carry other infections. As I mentioned, those are called co-infections. There's several listed: anaplasmosis, babesiosis, ehrlichiosis, Bartonella, and Rocky Mountain spotted fever are examples of these other tick diseases. So first stage, like any disease, we have early Lyme disease and late Lyme disease. Early Lyme disease develops after one of the infected ticks empties its contents onto your skin. Approximately 50 to 60% of patients develop a rash. You may have heard the rash referred to as a bullseye rash. It doesn't always have to have a target in the middle of it. So now the more common term is called an erythema migrans rash. Erythema means red, and migrans means expanding. And the rash really has to be a little sizable to be considered a rash that would classify as a Lyme rash. I have this little clear ruler. It should be about 2.5 inches in diameter, because sometimes patients come in and they have teeny little bullseye rash about that big. and that really is suspicious, but really not classical. So it really has to be 2 or 3 inches in diameter. The rash can be circular, it can be oval, a patient can have multiple rashes on their body. They're usually not itchy and they're usually not painful, which differentiates them from the 2 most common other rashes Lyme is confused with, which are spider bites, which are also often very painful, and ringworm, which is often very itchy. Rashes may appear 3 to 30 days after a bite. So we're really not sure. We're not sure if that's because patients are different or their immune system is different, or it has to do with the number of bacteria that are actually present in the tick that bite you. And of course, ticks can feed for a variety of lengths of time. Early Lyme disease can be asymptomatic. Approximately 18% of patients who have early Lyme disease never see the tick that bit them. Most common symptoms in early Lyme disease: headache, chills, fever, muscle and joint aches, and swollen lymph nodes. And just one point I would like to make, if you actually have a bullseye rash, that's Lyme disease. Sometimes patients say, oh, my test was negative. You don't really even need a blood test at that point because that is considered first-stage Lyme disease. Some of the studies now do blood tests with the bullseye rash because we're using that as the criteria for the study, but not really that it's needed. That's definitely Lyme disease if you have a bullseye. Treatment at this stage is highly effective. 2 to 4 weeks of medicine, usually doxycycline, moxicillin, Ceftin. Doxycycline is very sun-sensitive, so unfortunately in the summer that may be difficult to use. If a patient works outside or if they're a lifeguard, they can really get bad skin sensitivity from that. So there are other choices if you have allergies to any of those medicines as well. If a patient doesn't notice a tick bite or they never have a rash, unfortunately, they may proceed to the second stage of the disease, which is called late-stage Lyme disease, disseminated Lyme disease, as the bacteria spreads in the bloodstream to other parts of the body. The areas that the Lyme may spread to involve the central nervous system, which is the brain, the peripheral nervous system, which are nerves, and of course, joints, and the cardiovascular system. Joints involved are usually larger joints like knees, hips, the neck. It's infrequent to have the little joints in the hands involved, wrists, elbows. So the type of joint involved is something that has to be taken into consideration. Also, infectious types of arthritis can cause migratory problems. So patients with Lyme disease may say, my knee hurt one day, and then next week my hip hurt. All types of infectious arthritis, and there are of course other types besides Lyme, have this phenomena where they move from one part of the body to the other, and that's uncommon with what I'll call regular old arthritis, like osteoarthritis or rheumatoid. So the migrating feature is very characteristic of Lyme. And then patients during this stage also have more significant other symptoms. They have very significant fatigue. Patients say, I'm driving to work, I usually drive 10 minutes and I have to pull over because I feel like I'm going to fall asleep when I'm driving. Patients can have sleep disturbances, they can have insomnia, and a lot of times patients get night sweats during this phase. So they're up sweating almost like they have a flu or something of that sort. Patients can be irritable, sometimes that's just secondary to not feeling well. Cognitive dysfunction, headaches, and also paresthesias, which are pins and needles, can be seen in this later stage of the disease. The variety of clinical manifestations is felt to be caused by 2 factors, which is the biodiversity of ticks, that there's a lot of different strains of Lyme disease that are present in the ticks, and also patients are so different. So if a patient has, let's say, rheumatoid arthritis or diabetes, and their immune system is perhaps not as good as someone who's 20 and healthy, they may get Lyme disease and have different types of symptoms than someone who's bitten by a different strain of Lyme. So laboratory tests for Lyme disease, we have several tests. The first group of tests, ELISA test, which is also known as a titer test, Western blot, and C6 peptide, those are tests that are indirect tests. They don't actually test for the bacteria, they test for your immune system's response to the bacteria. And C6 peptide is a type of ELISA test that looks at a little sequence of amino acids on the bacteria, so that's felt to be a little bit more specific. The Western blot, you may have heard of, that's the one that has the bands on it. It has two phases, IgM, which is positive when you first have Lyme disease, and then IgG, that part of the test becomes positive if you've had Lyme for a longer period of time. The thing about these three tests is they're antibodies. So sometimes, once you've had Lyme, these tests can remain positive because your body has an immune system. Just like if you had mono 20 years ago, you may always show some memory cells that you've had that before. So these tests have limitations in terms of using again and again to tell whether or not you have Lyme or not. Polymerase chain reactions, those are DNA tests. They can be done to DNA or RNA. They're very specific, meaning if you have those, it usually has a very high degree of accuracy. But unfortunately, sometimes they're not as sensitive. So you can have Lyme and they're not positive. And then it's important to also do the test for co-infections because sometimes they can be a culprit along with Lyme disease or on their own. So Lyme disease symptoms may mimic a lot of other diseases. So if you have a patient who said, I never saw a tick, I never had a rash, and I have headaches and joint pains, how do you approach someone like this? So it's very important in that situation to make sure that you're not missing one of these other diseases. And if you looked up the symptoms of all of these things and matched them to Lyme, there would be very, very good homology. So rheumatoid arthritis is, of course, the classic disease that in the beginning, a lot of people thought was Lyme disease. It has joint pain, it has fevers, it makes you tired, it's a systemic autoimmune disease that has to be looked at. Lupus, of course, it is a disease that involves the heart, the skin, you can have headaches, you can have joint pain, so very similar to Lyme. Fibromyalgia is a disorder where you have pain all over and fatigue and sometimes cognitive problems. Of course, Sjogren's syndrome, that's another rheumatology disease that has joint problems and rashes that can be confused with Lyme. Chronic fatigue syndrome. Hypothyroidism is a disorder that has muscle pain, it makes you really tired. And multiple sclerosis, which is a neurological disease that also has pins and needles and things that can be similar to Lyme. All of these things all have their own blood tests and should be looked at in a complex patient where unfortunately the diagnosis is a little bit more different. So you can see we have these it's called the differential diagnosis, other things you have to look at besides the usual stuff like are you anemic, your liver function, your kidneys, all these things have to be evaluated. So treatment, as I said before, early Lyme disease, doxy, amoxicillin, iloxifene, very well tolerated, usually works very well. Late-stage Lyme disease is a little bit more difficult. Just like any disease, if it's going on longer, it may need a little bit longer medicine or perhaps a stronger medicine. There also is, you may have heard, cases where patients need to use intravenous medicine. Those cases are usually where a patient has more significant or more severe symptoms where you really can't wait for oral medicines to occur. Like if you have a patient who has meningitis, where you just can't wait for the oral medicine to work, or the medicine has to get into the brain or areas of the body where usually orals don't penetrate. If a patient has Lyme disease in the joint, where we actually have to take a needle to away the joint, so we want to use medicine that's stronger and also has better penetration. And then cardiac Lyme, Lyme sometimes can affect the heart and cause heart block or pericarditis, which is an infection around the heart or an inflammation. Those are cases where sometimes we have to use more aggressive medicine, which is intravenous. And that unfortunately, sometimes despite treatment and weeks of treatment, patients don't get better. And this is an area now which is, I'll say, a little controversial and definitely very interesting in terms of what is driving this. Why are patients not feeling well? Because sometimes there's a patient who's really sick and fever and heart problems and they take the medicine and they are fine. Where there's other patients who say, I just didn't get better, So these are some theories now. There's a lot of different studies and papers about what is driving this, and it's actually called post-treatment Lyme disease symptoms. Patients who just don't get better. So one of the things that people are looking at is, do these patients have persistent infection? And I have quotes up there, persisters. There's actually a few studies at Johns Hopkins on this term. They coined this term. of bacteria that just don't seem to, like the survival of the fittest. And they have a really interesting study that they actually did in a lab, not in patients, where they took these bacteria and they grew them, and then they tried all different antibiotics to see which ones could kill these stronger bacteria. And they have a list of them, and they're looking at this, of course, in the laboratory. We're really not sure now if we can then use these medicines in patients. But that's kind of an interesting area. And it's postulated perhaps 10 to 20% of people who have had Lyme fall into this persisting category where they just don't get better. Second thing is that some people, besides Lyme disease, have one of these other tick diseases that may require a completely different medicine. So here's a time where you definitely want to check for the co-infections. Third thing is some people just don't have a great immune system, and there can be bacterial debris, is kind of the term we use for this, little pieces of Lyme bacteria that your immune system isn't able to clear. And there's some really good studies in mice about this, that this may then be driving the patient's symptoms, that they're not improving. And then my field as a rheumatologist, autoimmune diseases, auto means self. So these are actually diseases where your body is attacking yourself, like lupus and rheumatoid. And even before anyone knew about Lyme disease, we always knew that infections could trigger these diseases. And they all have, or most of them have, a genetic predisposition. So if your mom had rheumatoid and your cousin has lupus, you may carry a gene for that, and you may go your whole life and never get those diseases. But there's something about certain infections that can trigger those. It can kind of turn on the switch. So in a patient who has Lyme and has symptoms that are not resolving, especially if they're joint related, it's really important to check to make sure the patient doesn't have one of these entities. And then unfortunately, sometimes people have Lyme disease and they have damage. They may have Bell's palsy. They could take medicine forever. If that nerve is damaged, the patient is better off going to physical therapy, doing other treatments to try to help the nerve function, but that doesn't always mean that there's still an infection. So unfortunately, damage does occur. It happens much less often now because we're so focused on early treatment that a lot of patients don't get to those stages. And then lastly, unrelated, sometimes patients may have 10 different symptoms with Lyme disease. They take the medicine and 9 go away. Maybe that 10th is something else. That is just, life isn't fair. You can have another disease too. So it's really important to look at all of these things when you have a patient who doesn't get better. And as I said, this is kind of the real area for research now because we're doing very well with early treatment. Patients, especially in New Jersey, are so knowledgeable about finding a tick, checking themselves over, that we've improved our treatment of early Lyme disease dramatically. And this is an area where we really feel we have to put much more of our concentration into finding out what is the problem with our patients. So that's it, a whirlwind tour of Lyme disease. I didn't mention anything neurological because our next speaker is going to review that. Thank you.
Okay, I'd like to introduce our last speaker. Our last panelist tonight is Dr. Halperin. Dr. Halperin is the chair of the Department of Neurosciences at Overlook Medical Center and is the medical director of neurosciences at Atlantic Health System. He was previously the chair of neurology at North Shore University Hospital. He is a professor of neurology and medicine at Thomas Jefferson University. He currently is the chair of the New Jersey Stroke Advisory Panel and is active in the American Academy of Neurology, where he serves on the Guideline Development Subcommittee, and he frequently teaches the Nervous System Infectious course. He currently serves on the editorial boards of Neurology, Current Neurology, and Neuroscience Reports, and he's a section editor for neuroinfectious diseases. I'm getting all this? Okay.
More than my mother did.
And additionally, he is the author of approximately 200 peer-reviewed publications and book chapters. I'd like to thank Dr. Halperin for being here tonight, and he's going to present.
Thank you. Thank you all for coming here. I'm going to start by asking Amy, could you send that slide to my dear, please? They haven't read it, and they'll eat anything. My wife, who's the world's biggest pacifist, is ready to get a shotgun and go after them. She's really...
That's the only way.
So the first is a quiz. Again, I'm going to pick on Amy because of your specialty. What is that picture in the upper right-hand corner, and why is it relevant? It's just for entertainment value.
It's a river, but I don't know which one.
Andrea, you want to guess? This was about a year ago. I was flying out of Newark Airport going northeast. That's the Connecticut River, and just below the engine there is Lyme, Connecticut. So since I was flying to give a lecture on Lyme, I couldn't resist taking a picture of it. So that's where it all began. So I'm a neurologist. I'm going to share with you a little bit about a neurologist perspective. I also have a great advantage following two such great talks, which is number one, I can skip half of what I'm going to say, and number two, with impunity, I can kibitz and pick on things and elaborate a little bit. So it gives me license, and I'll take advantage of that. So you've heard a lot about this various things. The bottom left-hand corner is a mailer I got in the mail yesterday for the mosquito squad that will get rid of ticks anywhere you want. Those curlicues in the middle are Borrelia burgdorferi. Those are the bugs we're talking about. It's a family of bugs. We tend to think of Lyme disease as being an American disease starting in Lyme and Old Lyme, Connecticut. In fact, the Europeans discovered this over a century ago. So the skin rash that we talk about as erythema migrans, or originally erythema chronica migrans, was first described by the Swedes in 1910. The neurologic manifestations were first described in 1922 by two French physicians, Garin and Boujadou. I'm going back and forth with Gary Wormser, who's a name that Andrea will know, on the translation of that article, because he has a niece who speaks French, and I grew up in Montreal, so we're trying to get a better translation than is out there. When Garin and Boujadou described a wonderful case report of a retired French foreign legionnaire who he was a sheep farmer, he had a tick bite, he had a rash that took over both sides of his butt and up his chest. He developed neurologic manifestations, had meningitis. And these guys in 1922, knowing very little about anything, concluded it was a spirochetal infection. A quite remarkable and probably based on absolutely nothing sane. But they gave him the state-of-the-art treatment for neurosyphilis, the other spirochetal infection, namely mercury and arsenic, and he got better. I think it's miraculously they didn't kill him, but he got all better. So go figure. Anyway, the point of all this is that when we think of this as a disease that's fairly recent, there's really a century of information about it. So the Europeans were treating this infection, although they didn't know what it was, but they were using penicillin in the 1950s. So there's a long history of treating it with antibiotics. Alan Steer and his group at Yale and Jorge Benash and colleagues at Stony Brook, which is where I first got involved with this, both got heavily involved in this in the 70s. Sad to say, I was involved in this in the 70s. You talk about way back then, thanks, I appreciated that. At that point, Lou Reich at Yale and myself at Stony Brook got very interested in the neurology of this, and that's where a lot of this story evolves. So we know the bacteria, we know the vector. That just shows not only the U.S. map that Amy showed, but also this is a disease that cuts across central Eurasia, goes through temperate climates, through much of Europe, Russia, China. That deer is prancing across my back lawn, thank you very much, despite every plant that Amy told you it resists. There you see the family portrait of the tick. One thing I'll say about the tick that's sort of, it's a little detailed and maybe a little gross, but it sort of helps you understand some important things. So the egg hatches and the egg is not infected. There's not what's called transovarial transmission of infection. So then the egg hatches, becomes this larva, and the larva is uninfected. The only way the tick gets infected is by feeding on an infected something. And the preferred host for the larva is a mouse. So if he or she, I guess it's an it at that point, feeds on an infected mouse, the tick may well get infected. If it feeds on an uninfected mouse, it won't be infected. It then graduates to its next life cycle, the nymph, which I like to call the teenager because it causes most of the mischief. And then if that nymph was infected and bites you, your blood gets taken into its abdominal contents, that stimulates the spirochetes that have been living there since its last meal. The stimulated spirochetes multiply, migrate through the tick, go to the tick's salivary glands, and then get injected into you. That's a process. That process takes 24, 36, 48 hours. And because of that, the tick has to be attached to you really for at least a day, probably two, before you're at serious risk of being infected. What this means is if you see a tick crawling on you, probably not much of a risk. If it's attached and it's not particularly enlarged, probably not much risk. You want to watch the spot, you want to get rid of it, obviously, but not a lot of risk of infection. I'll show you some numbers in a bit that show you how low the risk of infection is after a tick bite. That's not to say don't pay attention to it and don't get rid of the ticks, but don't panic either. One of the interesting numbers about that rash is Andrea correctly told you that most of the literature says 50 or 60% of adults show the rash. In children, 90% of kids are reported to have the rash. The big difference between a little kid and a big adult is 50% of adults are males and are oblivious to everything. But the other thing is that in little kids, mom gives them a bath, Dad gives them a bath. So you get a pretty careful, thorough whole body check. For most of us, we do those things ourselves, and if the rash is on our back, it's painless, it's not itchy, and we may just, even a female may not notice that it's there. So because of that, the rate at which we see rashes in adults is lower. Whether there's a real difference or it's what's called an ascertainment bias is hard to know. As Andrea pointed out, skin involvement is the commonest. The couple, that's actually a couple on the right. It's a husband and wife. So I saw the wife when she came in with that erythema migrans on her neck. The thing that's characteristic, as Andrea pointed out, is the size. The thing that differentiates it from other rashes is the migrans refers to its enlarging over time. So it starts off small and it grows day by day by day. The biggest one I've seen was when my son was little, one of his friends came in from armpit to groin. It can be huge, and it's asymptomatic. If the kid's mom hadn't seen it, he was a boy, he wouldn't have noticed anything anyway, but he really was not upset by it at all. It wasn't painful, although it looked ugly. So the thing that's characteristic and differentiates it from just the bug bite itself, if you get bitten by a tick or a mosquito, you get an allergic reaction that gives you a little ring. That goes away in a couple of days. This gets bigger, 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 unless you do something about it. So very different from most of the rashes you're used to. So the story here is she did the gardening, got the rash. She was treated, did fine. The next year she made her husband do the gardening. He got bitten. He got 25 rashes. Moral of the story is they moved to Florida and neither of them does the gardening anymore. There's a very recent Swedish study I just put up there just to keep things in perspective. Around here, what's the guess, Amy? 20, 30% of ticks are infected, probably, ballpark? It's a subset. It's less than a majority. Sweden has areas that are very highly endemic, so in that area, 45% of ticks are infected, which is a really high percentage. They got 1,546 tick-bitten Swedes through their study, and they followed them. Of that 1,546, 33 got a rash and a symptomatic infection. Another 45 never had a symptom in their life but developed antibodies in their blood. So 5% of people who get a tick bite with infected ticks get anything at all. All of those people were treated. We treat an asymptomatic seropositive because we really don't know what's going to happen. Likelihood is, like every infection that's out there, the majority of people who get any given infection have an asymptomatic infection, get rid of it by themselves, and it's not a problem. None of us really has the courage to see a patient who has a positive Lyme test and not treat them, so everyone will get treated. Point is, don't panic, it can happen. Watch the area if you see a rash. As Andrea correctly said, if you see the rash and it's a typical one, less than 50% of people will have a positive blood test at that point. We treat that rash. We don't wait for the blood test. We don't wait for it to convert a month later. You just treat the rash because really there's very little else that'll do that. This just talks about that. That is a Western blot in the lower left-hand corner, because you'll hear the term. What you see are those horizontal stripes, and what each of those represents is an antibody to a different size protein in the Borrelia burgdorferi, the bug we're talking about. The ELISA measures the total amount of antibody you have, which is a quantitative test we use. It's automated. It lets you compare how much antibody you have compared to a bunch of other people. Because our antibodies cross-react among different things, when someone has antibody present, we then look with the Western blot to see if it's specifically the antibodies that mark this infection. So we do the ELISA first, and then if that's positive or iffy, we'll go ahead and do a Western blot. As Andrea said, the IgM is only used in early disease. If your disease has been there for more than a month or two, you really should have this other type of antibody, IgG. And I often see a patient who only has IgM antibody but has had symptoms for 2 years. That's clearly irrelevant. It's called a false positive. It's just a common artifact that happens in the lab and is not meaningful. So we have to be careful with these tests about early on negative results that aren't really negative because you haven't developed the antibodies yet, and later on false positives that are confusing. And the other thing, again, as Andrea pointed out, when you have any infection, you continue to make antibodies for the indefinite future. So finding antibodies today means that you had an infection at some point in your life. It may or may not have any bearing on what's going on right now. So just a couple of things that you'll hear out there. Someone says, well, I had a negative blood test, but I was taking antibiotics at the time. This actually comes from a paper that several colleagues and I wrote in 1989. We were wrong. It was an artifact of the technology we had in 1989. And basically, taking antibiotics right now has no impact on the amount of antibody in your blood. It just doesn't do anything. In fact, as far as negative standard blood tests in general, again, this comes out of literature from the 1980s, and with technology we have today, is only an issue in the first 3 to 4 weeks or so. The Western blot, sometimes you'll see people who say, I have a band on Western blot, but everything else is negative. What does that mean? The answer is nothing. Antibodies cross-react with all sorts of things, so just seeing a band or two has no diagnostic significance whatever. And as I mentioned, after you've been treated, the antibody may stay positive indefinitely, so you have to take it within that context. Treating someone may cure the infection, obliterate the infection, the blood test will stay positive. Some people argue that you should treat and treat and treat until the antibody goes away. That's nonsense. You'll end up treating the rest of your life in many people. There are some what are called specialty labs that have their own assays. They really aren't validated and don't correlate with what most people consider to be real Lyme disease, so be careful with those. That's my granddaughter. She used to feature more frequently in this, but I couldn't get it on all the slides. She's a very thoughtful young lady, the most beautiful, brilliant 4-year-old you'll ever meet. Thank you very much. The reason a neurologist is here is that there's been a lot of talk over the years about neurologic disease and Lyme. Andrea talked about multiple sclerosis, and there's been a lot of other stuff. And as a neurologist, I have to be very careful about that. You've heard there are no atheists in foxholes. There are no non-sweaty palms in a neurologist's office. If you ask a population what type of disease is most terrifying to them, above heart disease, above cancer, is brain disease. You say you have a neurologic disease, you have struck terror into that person's heart, you damn well better be sure that you mean it and you're not mistaken. So it's really, really, really important that people understand what is and is not neurologic disease, and that underlies a lot of stuff that's out there that's caused a lot more anxiety than is necessary. So, neurology reduced to one slide. My job, what I do as a neurologist, is try to identify diseases of the nervous system. What you have to understand is there are many different things that affect how your brain works. You don't get a good night's sleep, the brain doesn't work well. You have the flu, the brain doesn't work well. You had anesthesia yesterday. My wife had hip surgery 2 weeks ago. She was pretty goofy for about 36 hours. It was interesting. Quite entertaining, actually. So, medications, all these different things that we know change our behavior, but really have nothing to do with neurologic disease. So just because someone is tired, has some pins and needles tingling somewhere, has a headache, that does not mean they have neurologic disease, and it's very, very important to remember that. So what does Lyme disease do? Well, the commonest is, again, a word that strikes fear into people's heart, which is meningitis. The word meningitis means inflammation of the lining of the brain, what we call the meninges. Now, there's a form of bacterial meningitis caused by what's called meningococcus that's a lethal disease, and every so often you'll read in the paper about some high school or college students who got meningitis and died in 12 hours. That's obviously terrifying. But that's a very small minority of meningitis. The commonest cause, 10 times as common as bacterial meningitis, is viral meningitis. If you have viral meningitis, you have a wicked headache, you feel terrible, you feel like you were run over by a truck, but it's completely benign. It doesn't damage the brain, it doesn't do anything except make you feel miserable for a week or maybe longer. So although it's a terrifying word, in and of itself, it just means inflammation of the lining. Headache, yes. Sensitive to lights, yes. Cranky, undoubtedly. Fever, yes. Harmful to your health, no. Okay. The next most common thing that happens is the nerves that come out of the back part of the brain and go primarily to the skull, what are called the cranial nerves, are not uncommonly inflamed. The commonest one is the nerve that controls the muscles of the face, and you get a paralysis of one side of the face, similar to what's called Bell's palsy. So the whole side of the face gets paralyzed. It's not a matter if you look in the mirror and you think it looks 2% crooked. It's your mouth is drooping, your eye can't close, you're drooling out of the corner of your mouth when you try to drink. It's not subtle. It's not something that you can debate. You just look at a picture and you say, my God, what's going on here? So that's the commonest. It can affect both sides of the face. And then the other thing that happens is what happened back in that 1922 case, which is an inflammation of the peripheral nerves. That's the nerves that go from the spinal cord out to the rest of the body. That can be very painful, as it was in the case described by Garin Boujardou. It can cause muscle weakness. It can cause sensory loss. And then you can get other forms of nerve inflammation. All of those things cause weakness that's localized, in a neurologist's word, to the area controlled by that nerve. All of it can cause sensory loss, changes in the things that a neurologist examines. And, for every patient I see who has a neuropathy, damage to nerve, I'll see 100 patients who have subjective symptoms of tingling or numbness or something else, but are neurologically completely normal. There's no loss of nerve function. And if I do an electrical test of the nerve to test it, I find nothing. If I even took the nerve and looked under the microscope, I'd find nothing. So it's very important to understand that there are all these symptoms that we all experience every day. You lean on your elbow, you get numbness and tingling. So these are very, very common things that occur very commonly. And just because you have a symptom in column A does not mean you have a disease in column B. And this just sort of gives you my schematic of all the different things that affect behavior. That's how we judge the nervous system as behavior. But remember, it can be affected by systemic symptoms, systemic illness, systemic variation, fatigue, or whatever. It can be affected by psychiatric disease. It can be affected by all sorts of different things, and only a small subset of that means you have damage to the nervous system, which would be the most worrisome cause of it. Now, the discussion of post-Lyme disease syndrome or symptoms is a fascinating discussion and probably the greatest cause of debate, and Andrea and I could probably go at it for about 3 hours on it. But it's fascinating, and the biggest challenge with it is that there's a symptom complex which involves fatigue, a sense of mental slowing, often some numbness, tingling, a variety of symptoms. People are functioning terribly and have a tremendous difficulty. And the bottom line is we don't know what causes that. We really, really don't know. And it turns out if you do a population study, at any given time, a third of the population will have a mild version of that, and 2% of the population will have those symptoms to a degree that it's significantly impairing their daily function. These people are really having trouble, they're really sick, and medicine doesn't have an answer for them, and that's frustrating to us as physicians, and it's certainly frustrating to the patients. Over time, in medical history, periodically there have been explanations floated, associations that have been thought to be causal, most of which have fallen by the wayside. Since Lyme is known to cause this symptom complex in people who have the acute infection, it's a perfectly logical assumption that there'd be some relationship. If you just think of it quantitatively, though, it's really a challenge to establish that there's a causal relationship between the two. If you look at, let me just skip over that. Probably the best study of this is by a psychiatrist at Columbia by the name of Brian Fallon, who did a major study of patients with this symptom complex and treated them either with 10 weeks of IV antibiotics or 10 weeks of placebo. They'd already been treated, and they had these symptoms after they'd been treated for Lyme, and found that that treatment didn't change their symptoms. But there's more to that study than that, that's interesting. One is that he's nationally known for his interest in this syndrome. He recruited nationally for this study. He screened 3,300 patients plus to get some who he thought had Lyme disease and had this syndrome. And about 1% of the patients that he screened actually met reasonable criteria for maybe having this diagnosis. So you have a disease that occurs, or a syndrome that occurs in 2% of the population, in a population already selected for thinking they have this syndrome. Less than about 1% had the syndrome. Is it coincidence? Is it causal? I don't know. And I think it's unanswerable. There are a couple of reassuring things out there in general from a quantitative perspective. One is from this and about 5 other studies, we know that this is not something that antibiotics cure or change. So that's reassuring to me because it means there's not an ongoing infection. And this has been studied exhaustively. The most recent study was just published a few months ago. It was 280 Dutch patients who had this syndrome who were treated. First, they got 2 weeks of IV antibiotics, then they got 12 weeks either of oral doxycycline, oral Biaxin, and Plaquenil or placebo. Outcomes were identical in all 3 groups. Then there are 2 prospective studies, one out of Westchester, one out of the NIH, where they took over 100 patients who had unequivocal Lyme to start with and just followed them over time. And this syndrome was not a disabling syndrome in any of the patients they tracked over time. So this doesn't prove it doesn't exist. It doesn't prove what's causing it. It does sort of set some bounds on the frequency of it and what your level of concern should be about it. The honest answer is it's scientifically a fascinating issue that's being vigorously looked at in many ways. What we do know about this, it's not antibiotic responsive. People talk about antibody-mediated. It could be, but there's absolutely no correlation between the amount of antibody in your blood and what happens to you. You heard Andrea talk about persisting bacteria or debris. That's been shown in mice, never been shown to happen in people. If you think about it, the concept of that is the debris or bacteria are hidden from the immune system. And then you have an interesting dilemma, which is we know the bacteria don't secrete anything into the bloodstream, so they can't cause a syndrome by something they secrete. We're saying they're hidden from the immune system, so there's no host immune attack on them. So how do we get from that debris or bacteria to any symptoms if you don't have an immune reaction and they're not making anything? There's just no easy way to get from point A. The concept of there being some alteration of the immune response that's triggered by the infection, it's plausible, it's being tested, people are looking at it. That may be an answer. There's some very interesting behavioral observations on this. We know that this syndrome is not depression. We know it's not major psychopathology. We know people aren't malingering. It's very real. But there's some personality characteristics that seem to make people more at risk of this than others. There's something called resilience that psychologists talk about. Hillary Clinton the other day, it's not if you're knocked down, it's if you pick yourself up. People who get sick and bounce back right up, as opposed to people who get sick and it really sets them back more. And a lot of that has to do with how you deal with physical stressors, medical stressors, psychological stressors, and that's sort of wired into us at a very early age. So all of these are hypotheses that are out there. They're being actively tested by groups that are looking at it. This is a large number of people who are suffering from these symptoms, and we're very concerned about them. We don't have an answer, but we really want to find the answer. The thing that's clear from what I've seen is that there's no evidence there's a persistent Lyme infection causing this. So does Lyme affect the nervous system? Absolutely. 10 to 15% of people will get one of those syndromes that I described. Does not cause MS, should not be confused with MS, at least not by a neurologist. You need to sort of keep it in that context. So I think you wanted to throw it open to questions at that point. So.